Hello and welcome! Today, we are cracking the code on something I think we've all stared at in confusion, the medical bill. We're going to pull back the curtain and demystify how a doctor's visit actually gets valued and turned into a specific charge.
I mean, you know that feeling, right? You have a quick chat with your doctor, maybe 15 minutes, and then weeks later, a bill shows up with these codes and a price tag. How in a world did they land on that number? Well, that's exactly what we're going to figure out today.
So, here's the deal. For a long time, billing was based on this really rigid, kind of clunky checklist system. It was all about counting things. How many body parts did the doctor examine? How many questions did they ask? But that's all changed. The new system is way more flexible and honestly makes a lot more sense. It's designed to value what a doctor really provides, their thinking and their time. So now, a visit is valued based on one of two things, either the complexity of the doctor's mental work or the total time they spend on your case that day.
Now, to make this all super clear, we're not just going to talk theory. We are going to follow the story of a single patient, a 65-year-old, as their medical situation gets more and more serious. This is going to show us exactly how these coding rules play out in a real-world setting.
Okay, so our story starts with a pretty minor concern. Our patient comes in with some swelling in their leg, but there's no pain. The doctor takes a look and thinks, okay, this is probably just a simple circulation issue, what's called venous stasis. They're not worried about an infection. So the advice is simple. Elevate the leg and check in with your regular doctor. Seems straightforward enough, right?
And because it's straightforward, the coding is too. Let's look at the scorecard. The problem addressed was minimal, just one simple issue. The data needed was minimal, no tests, no old records, and the risk was also minimal. The treatment was just some simple home care. When you've got minimal, well, you get what's called a straightforward level of medical decision-making, or MDM. That's the lowest level of complexity.
But of course, a few days later, the situation changes. Our patient is back, but now that same leg is painful and warm to the touch. This time the doctor has a clear diagnosis, cellulitis, which is a common skin infection. They take a quick look at the patient's past records and write a prescription for a standard antibiotic.
Okay, so watch how the scorecard changes. The problem is now a low complexity. It's a new but uncomplicated illness. Because the doctor looked at an old note, the data gets bumped up to limited. But here is the real kicker. Prescribing a drug, any prescription drug, automatically pushes the risk level up to moderate. Now here's the rule. You only need to meet the criteria for 2 out of the 3 categories to determine the final level. So, because we have a low problem and limited data, the whole visit is coded as low complexity MDM.
So, we've been throwing this term around, medical decision-making, or MDM. Now that we've seen it in action, let's take a second and really unpack what those 3 core pillars are that determine how complex a visit really is.
The best way to think about it is like a detective solving a case. Step 1 is the problems. These are your suspects, the number of issues and how tricky they are. Step 2 is the data. These are all the clues. We're talking lab results, old records, even talking to other doctors. And step 3 is the risk. These are the stakes of the case. What's the potential for something to go wrong, either from the illness itself or from the treatment?
All right, let's get back to our patient, because the plot is about to thicken. They come back again, and this time, things are clearly more serious. They have a fever. Now, a fever is a huge clue for a doctor. It tells them the infection isn't just in the skin anymore. It's now affecting the entire body. It's gone systemic.
And this is a perfect moment to see how that data pillar gets bigger. It's so much more than just lab results. In this case, the doctor orders a couple of unique tests, sure, but they also get on the phone with the patient's primary care doctor to talk through the case. That phone call, that counts as data. If the patient was too sick to talk and the doctor got information from a family member, that counts too. It's all part of the detective work.
The risk also goes way up. And again, risk isn't just about the illness. It's about the gravity of the decisions the doctor has to make. Prescribing a new drug, deciding to do even a minor surgery, or the big one, making the call to hospitalize someone, all of these things increase the risk. And it's not just medical stuff either. Social factors, like if a patient is homeless, can complicate treatment, and that adds to the risk level too.
So let's look at the scorecard for this visit. The problem is now an acute illness with systemic symptoms. The doctor ordered multiple tests and talked to another provider, and they prescribed a new drug. You see how all 3 pillars, problems, data, and risk, land squarely in the moderate category, and that makes the final MDM level for the visit, you guessed it, moderate.
And now for our final and frankly, most critical scenario. The patient comes back, and this time they are in very bad shape.
They're confused, their blood pressure is plummeting, and their heart is racing. The doctor immediately recognizes these as signs of a severe, life-threatening infection, possibly a flesh-eating bacteria, and makes the urgent call, "You need to go to the emergency room right now." This is where everything hits the absolute peak. The problem is now at the highest level, an illness that is a direct threat to the patient's life. The data is considered extensive because the doctor is getting information from the patient's daughter and then coordinating with doctors in both the ER and surgery. And the risk is high because of that massive decision to hospitalize the patient for emergency IV drugs and treatment. It's a textbook case of high-level medical decision-making.
But, and this is really important, remember what we said at the beginning? Medical decision-making is only one side of the coin. A doctor can also choose to code the visit based on the total time they spend on that patient's care for that day.
And this right here, this definition, is an absolute game changer. The key words are "and" non-face-to-face time. Total time isn't just the minutes you're sitting in the exam room. It includes all the work the doctor does for you on the day of your visit, whether you're there or not. I mean, think about all the invisible work that goes into your care. The time your doctor spends reviewing your chart before they even walk in the door. The time they spend after you leave ordering your tests or calling in a prescription. All the time it takes to write up detailed notes, to call another doctor to coordinate your care. Under this new system, all of that time counts. It finally recognizes all that critical behind-the-scenes effort.
And to put a real number on it, let's take a look at the highest level visit for an established patient. That's code 99215. To use that code based on time, a doctor has to spend a minimum of 40 minutes on your care that day. So if they spend 39 minutes, nope, they can't use that code. It has to hit that 40-minute threshold.
And what's really cool is that this system isn't just stuck in the past. It's actually being built to adapt to the way medicine is practiced today. You know, with things like telehealth and the growing need to manage patients with really complex long-term conditions.
A fantastic example of this is a new add-on code called G2211. Now, the name sounds technical, but the idea behind it is so important. This code is designed to recognize the extra work and the value of a long-term doctor-patient relationship. It adds value for doctors who manage a serious chronic condition over many years, or who act as the quarterback for a patient's care, coordinating with a whole team of specialists. It's a real step towards valuing continuous, thoughtful care.
And just so you know where all this information is coming from, everything in our explainer is based on the official reference guide from the Infectious Diseases Society of America, which itself is based on the core guidelines from the American Medical Association.
So, after all that, what's the big takeaway? It's this: the way we value our doctor's visit is fundamentally shifting. We're moving away from a simple checklist of actions to a system that tries to capture what really matters: a doctor's time and their expertise. It's about valuing the thinking, not just the doing.
And that leaves us with a pretty big question to think about. As our healthcare system gets better at measuring and valuing a doctor's cognitive effort, all that thinking, planning, and managing, how might that change what we prioritize and value in healthcare as a whole? It's a fascinating shift, and it's happening right now. Thanks so much for joining us.